This is a video of a patient with refractory GERD after two failed endoscopic anti-reflux therapy, and the patient underwent laparoscopic Toupet fundoplication. So this is a 44-year-old male with severe persistent GERD with a hard history of heartburn for with PPI dependent heartburn for 6 years. She underwent ARMA 2 years back, which failed within 3 months, and GERDX for 9 months back, which also failed within 6 months. So in on evaluation, she was found to have cholelithiasis. So my plan is to go ahead with laparoscopic Toupet fundoplication, considering she has severe GERD. So this is a video of anti-reflux mucosal ablation. This is called ARMA, which is the above images you can see, and the below image is actually the image of GERDX. So after going inside, the pars flaccida is divided, and on further exploration, we found that there is a accessory left hepatic artery, which after clamping we have seen, and then we have divided it after clipping, and then only we will be able to expose the right crus. So you can see the right crus now, and the peritoneum just medial to the right crus is incised. So because the patient had two anti-reflux endoscopic anti-reflux treatment in the last 1 to 1.5 years, so I anticipated some kind of fibrosis adhesion near the GE junction. So I was very cautious about exploring the GE junction in this case compared to the routine virgin cases. So after dividing the peritoneum, I went on to divide the phrenoesophageal membrane just anterior to esophagus. So you can see the medial border of the right crus is explored, and the GE junction can be clearly seen. So this patient on endoscopy, when I did a endoscopy for evaluation, she had a Hill's grade 2 hiatus hernia with severe GERD. Even after two endoscopic procedures, she had Demister score of 255. So this was definitely not a functional GERD. So definitely she needs something for a permanent relief. So in this scenario where there are two failed endoscopic therapies done, so that patient had normal manometry also. So I decided to go ahead with Toupet fundoplication. You can see I am just while dissecting, I am carefully dissecting the phrenoesophageal membrane, safeguarding the vagus nerve. This is the left anterior vagus nerve, and the right posterior vagus nerve is in the posterior aspect. We will find while doing the dissection. So little bit of after mobilization from the medial aspect, I decided to divide the mobilize the fundus. So this is the greater omentum, which I am dividing and staying close to the gastric wall. So here the short gastric vessels will come, and short gastric vessels will come, so I have to be very careful while doing this dissection. And as I go ahead near the fundus area, so because of the previous operations, endoscopic operations, so I anticipated some kind of difficulty while doing final bit of fundal mobilization. So I went through the literature and went through the previous operative history also. I read about it, what is ARMA and what is GARDEX, because these are two novel techniques, novel endoscopic techniques, which are being increasingly used for these GERD patients. But I was surprised to see that the even these are short. There are only short term studies are there, and the GARDEX has a high failure rate. Even in literature, I have found that almost 1 in 2 patients, almost 45 to 50% of patients fail within 2 to 5 years. And with ARMA, there is very selective kind of patient where you find that there is only Hill's grade 1 reflux GERD with no hiatus hernia, then only you opt for this procedure. And even though you do this procedure, there is also high failure rate, high recurrence rate, and within 1 year, 1 to 2 years, there is almost 15 to 40% of the recurrence. So until and unless further studies or further modification of these procedures can be done, and this is difficult. This I mean, the fundoplication, proper fundoplication surgery remains the gold standard because it is a time-tested technique. So now you can see I'm after doing the mediastinal mobilization, I'm doing the mediastinal mobilization of the esophagus. We can see there is a wide hiatus, so almost 2 to 3 centimeter hiatal hernia is seen. So in this patient where hiatal hernia is already there, this is probably aggravating the reflux things, and the endoscopic treatment failed because in a patients with existing hiatal hernia, GERD cannot be corrected without repairing the hiatal hernia, and with endoscopic procedure you cannot correct the hiatal defect. So this is definitely concerning thing, because whenever patients come with the increasing use of this endoscopic techniques, for surgeons we are bound to face some recurrent cases, and then you will be able to see some intraoperative adhesions, fibrosis near the GE junction. So I also became very slow and cautious while doing the dissection near the G junction. I removed the fat of the G junction, pad of fat, and trying to see the whether this fundus is being properly mobilized. Now you can see, so on the from the left cross I am separating the esophagus, but there are some fibrosis which is around the 3 to 5 o'clock position. Here you can see this is the area where retroesophageal window should be broadened. I am trying to increase the retroesophageal window, but you can see there is a little bit of attachment which is very densely adhered, the posterior aspect of the esophagus with the densely adhered with the left crus. So I am trying to dissect all around it first, and then maybe finally we'll be able to dissect the area. So this is the area where I am now dissecting. Now you can see there is some degree of adhesions, and it is densely adhered with the left crus also. So I was like from the opposite side I have dissected the trim the area. You can see there is adhesion with the left crus. Now with carefully with the cautious dissection with the harmonic shear, and making sure that I am not entering into the fundus or G junction, so I have dissected it all around, and final bit of fibrosis, you can see how dense fibrosis there, and now it has been completely release of the left crust. Now you can see there's a left crust fibrosis there, so a little bit of loss of left crust muscle fiber while doing the because of the previous procedure and the fibrosis. So now I am able to bring the fundus nicely through the retroesophageal window. So now I decided to close the hiatal opening first. You can see around 3 centimeter defects. It's a big hiatal defect, and using a non-absorbable V-lock, the PVT, I am closing the hiatal opening carefully. So thick bites are required so that the hiatal repair should be good, and but should not be too tight, because too tight hiatal repair, too tight a cruroplasty can cause postoperative dysphagia. So I in a patient with refractory GERD, I don't want to create a tight crural repair where the patient may face the postoperative dysphagia. So 3 to 4 bites I have given, and narrowed down to that extent so that one tip of instrument can go through the hiatal opening along with the esophagus. So once the hiatal repair is done, so I have checked for the proper fundal mobilization, and you can see it's nicely being mobilized, and the esophagus is nicely with around 6 to 7 centimeter of esophagus is mobilized into the abdomen. And now starting from the G junction, I am started creating the Toupet fundoplication. So here you can see we using a 20 ethibond suture. I am dividing the first bite just proximal to the G junction. So the wrap that I will be creating, whether it's a Nissan's wrap or the Toupet wrap, it should be starting from the G junction and go above. So the wrap should be lying on the lower part of the, starting from G junction and the lower part of the esophagus, and that will prevent the reflux and the recurrences of GERD. So the second bite is also being given. So muscular bite was given, and along with that both side esophagus and the stomach, and the right sided wrap is being created. So Toupet wrap is actually posterior 270-degree wrap, and it's a very good wrap. And Toupet wrap will prevent the reflux and also the chances of postoperative dysphagia, because I am avoiding a 360-degree wrap. Only 270-degree wrap will also keep the anterior 90-degree open, so chances of postoperative dysphagia is less. So now on the left side again I am creating the wrap starting from the G junction. You can see nicely keeping the anterior 90-degree open. So safeguarding while taking the bites, you should be careful that vagus should not come into your bites. And this patient had a nice postoperative recovery, uneventful postoperative recovery, and the reflux was immediately gone after the procedure. So incidentally this patient had cholelithiasis also. So after finishing fundoplication, I did the cholecystectomy also with the same ports after changing the patient position a bit. And now you can see after creating the Toupet wrap, I gave the fix the wrap, right side of the wrap with the right crust, and that is also an important step to prevent postoperative in the follow-up period, that will prevent wrap migration into the hiatus. Now they remove the umbilical tape and check for the anatomical restoration. So you can see the wrap is being nicely created and anatomy is being restored, and that completes the procedure. Thank you so much.